Today we will discuss the clinical assessment of ovarian reserve. I am Dr. Neeraj. Ovarian reserve assessment is not just about counting eggs. It is about assessing the functional capacity of the ovary to provide oocytes that are capable of fertilization. So it's crucial to distinguish between the quantity, the number of follicles, and the quality, oocyte competence. The latter is which is primarily determined by maternal age. So let's look at the static biochemical markers. The commonly used one is anti-Mullerian hormone produced by the glandular cells of the preantral and small antral follicles. AMH is the most reliable marker of follicular quantity. Unlike other hormones, it is relatively stable throughout the menstrual cycle and is not affected by GnRH agonist or pregnancy. So the normal value is 1 to 3.5 nanograms. Low or diminished is when less than 1 nanogram. High when it's more than 3.5. It is usually seen in OHSS and PCOD. The limitation is that AMH reflects the quantity, not necessarily the quality of oocytes. Day 3 FSH is another method that is measured using the early follicular phase, day 2 to 4. As the pool of follicles decreases, inhibin B and estradiol cells drop, leading to a compensated rise in FSH via negative feedback. So if the FSH is less than 10, generally indicates a good reserve. If it is more than 10 to 15, suggests a diminished ovarian reserve. Limitation is that FSH has intercycle variability and intracycle variability. So a single normal value does not rule out diminished ovarian reserve. Imaging. Antral follicle count is commonly used via transvaginal ultrasound. The sum of follicles measuring 2 to 10 mm in both ovaries is taken. Normally 10 to 20 follicles are there. Diminished ovarian reserve is less than 5 to 7 follicles. Clinical value is that AFC provides an immediate real-time assessment of the functional pool available for that specific cycle. So it's of great importance in managing infertility and IVF. Dynamic and emerging markers are inhibin B is produced by the small antral follicles. It has low sensitivity and rarely used alone in clinical practice. Clomiphene citrate challenge test was used previously, but is mostly historical. Ovarian volume, total volume of the US correlates with the reserve, but it's a late stage marker of depletion. Now, how do you interpret this? Age and reserve are to be interpreted in this context. A 25-year-old having a AMH of less than 0.8, which is low, has a lower quantity but likely better quality, lower aneuploidy rate than a 42-year-old with the same AMH level. Oral contraceptive use, while AMH is generally cycle independent, long-term use of OC pills can suppress AMH levels by 20 to 30%, leading to a false diagnosis of DOR. Endometriomas. The presence of an endometrioma or prior ovarian surgery significantly impacts AFC and AMH, often necessitating aggressive approach to fertility preservation. Now let's see the management algorithm for diminished ovarian reserve. If assessment reveals a diminished ovarian reserve, it is an endocrine or fertility setting, it is an emergency. Immediate counseling to discuss the shortened reproductive window should be there with the patient. Aggressive stimulation protocols use higher dose of gonadotropin and fly-up protocols in IVF. As an adjuvant therapy, DHEA and coenzyme Q10 has some mixed evidence for preserving the mitochondrial function in the available aging oocytes.